everybody, and welcome back to the Bodcast. So my guest today is, as promised, the return of my favourite women's health physio, Jo Gipson. So in the last episode, we talked about what is the pelvic floor in general, the kind of clients that Jo tends to see, and the kind of symptoms that she tends to treat. And then we went into kind of pre or antenatal approaches to physio and training and preparation for childbirth. And I thought this episode, we could kind of pick up from where we left off on the childbirth kind of conversation and now start to delve into the postnatal period, what to do, when to do it, and why to do it. So welcome back, Jo.
Thank you for having me back.
No, it's great. You know, our last podcast got so much great feedback. I don't think I've ever had such great feedback on a podcast ever. So I'm really excited.
I think it's a really popular topic that people often don't feel is very well explored, or the information is so mixed that people really enjoy hearing about pregnancy, postnatal journeys. I think it's a really exciting place to be.
Yeah. And we all have a pelvic floor and a core. So we all all need some help. Okay. So like I say, let's pick up where we left off, which was kind of childbirth and preparation for childbirth and things like that. So when it comes to your clients who've just had a baby, what are the first things that you do when you assess them? And does this differ depending on the type of birth the patient had?
I often see new mums at really different stages. So some people I'll call at 2 weeks postnatal as a bit of a check-in to see how they're getting on. Some people haven't even heard of me or been interested in me until 9 months postnatal and they've got a problem. So I think it's always quite good to check in. Where is the person who I'm speaking to? How are they feeling? How are they sleeping? How are they getting on with their baby? How are they getting on with family life? Because although obviously as a pelvic health physio, I think that pelvic health is so important and I will talk about it all day long, shout it from the rooftops. But actually, if everything else isn't going that well, then it's hard to prioritize your own pelvic health. So I think it's always important to find out how is the person who I'm talking to actually getting on. But then if everything's going okay and they're obviously coming to see me to find out a bit more about how they can get their body doing all the things they want it to after they've had their baby. And so the first thing we're obviously going to talk about is the pelvic floor. So we spoke about it briefly in our last podcast. So it's a muscle that goes from the pubic bone to the tailbone and out to both sit bones. And it supports the bladder and the bowel. It is important for vaginal control. It's important for managing the pressure in our abdomen, so our intra-abdominal pressure. And so it's actually really quite common to have problems with the pelvic floor after having a baby. So depending on the stats that you read, it's about 1 in 3 women that suffer with urinary incontinence, 1 in 2 to 1 in 6, depending on the research, that might suffer with a prolapse, and about 1 in 10 that might suffer with fecal incontinence, so incontinence of the bowel, which is a lot higher than I think people take register for, really. So asking people about how their pelvic health is going, do they have any of these symptoms, is a really, really big part of what I'll assess. And I think we assess that via a vaginal examination if they feel comfortable. And that way we can check, is the pelvic floor, is it strong? Is it flexible? Is it coordinated? And what's its endurance like? And we can also see, is there any asymmetries between the left and the right side of the pelvis? Because I think we think of the pelvic floor as this one sheet of muscle that does a job. But actually, in the same way that we have 2 glutes, we have 2 biceps, we have 2 arms, 2 legs, we have 2 halves of the pelvic floor. And so making sure that both sides are working well together is also really important. So that's probably the first thing that I assess and the thing that most people come talking to me about. The second thing that everybody is really keen to talk to me about is a tummy gap or a diastasis. So as we mentioned during pregnancy, 100% of women will have a diastasis. And to try and prevent having one during pregnancy is pretty futile because actually, a lot of it's to do with your genetics, where your baby sits, how big your baby is it your first baby, what's your connective tissue like? So the sort of extent of the diastasis is predominantly determined before you've even got pregnant. There's obviously things that you can do during pregnancy, avoiding hard doming, managing pressure when you're exercising, doing exercises appropriate for you. But we know that sort of immediately postnatal, all women will have some sort of diastasis to recover from. Sort of the timelines and the research has really varied. We used to say a long time ago that anything after a 2 centimetre gap, 6 weeks postnatal, was considered a diastasis. But then more research has come out and it's shown that actually a lot of the healing takes place very, very quickly in the first couple of weeks, but there can be changes all the way into that first postnatal year. similarly, it's very, very common to have a gap of up to 3.5 centimeters.
I did, didn't I? Mine was quite,
very much.
yeah.
And you were really worried about it at the time.
Yeah.
And it's fascinating in terms of the research that comes out about diastasis. Physios and doctors and obstetricians used to say, it doesn't matter how big the gap is. It doesn't matter what it looks like. All that matters is function. And they did loads of research and realised that, women care about function, but they really care about what it looks like. They really care.
Yeah.
And I think to undermine that is naive, because, we want to help women with the problems that they experience, not the problems that we think they do or don't have.
Oh, yeah. No, I have, like, on the other side of it in my industry, I have it too, and I'm all for it. I talk about it all the time, and a lot of my listeners will know exactly what I'm about to say. I'm all for the self-love community. But you can't then shame women who do actually care how they look and do care about their physique. It's kind of like, you got to dance with the devil. Like, better to do it healthily than deny that it's even happening. And then that breeds unhealthy approaches. Anyway, sorry, continue, Jo.
No, I completely agree. And there was a very interesting study that came out this year, and it was predominantly looking at do curl up exercises or twisted crunches and all those sorts of exercises, which lots of people are scared to do during postnatal recovery. Do they make diastasis work? And do they increase the gap? Do they decrease the gap? They're trying to find out what happens. And so that was their goal. But what they actually found was that doing all these exercises did no harm, but didn't improve anything. But interestingly, after a 12-week program, the women in the control had a perception that things had improved, purely because they'd been told, go about your daily life. You're not going to do any harm. You're fine. Get on with it. And actually, they improved. And the people that did the exercise also had a perception that they improved, because they were doing all the things they wanted to do day to day. And they were doing all this exercise that made them feel stronger and made them feel empowered to move and be strong and do the things they wanted to do. So actually, it is true that the gap is not hugely important, but actually empowering women to feel safe and confident to move is huge. And going back to our previous point, over 70% of the women who applied to be part of the study thought they had a diastasis. And when they assessed them, they didn't meet the criteria. They didn't have one. They didn't have one that was big enough. So I think largely because of social media and this whole sort of awful bounce back culture, people are, think that their abdomen has to look exactly like it did pre-pregnancy, 2 weeks after having a baby. And if it doesn't, then it's not okay. Actually, it's really, really common to have abdominal wall changes, skin changes, muscular changes. And the most important thing is that you feel empowered to move, empowered to exercise. You're not scared of your own body, and that you can feel comfortable with the aesthetics, however that comes, whether that is through rehab, whether through that's, through learning to love your body, whether it's through surgery. There's lots of different ways to do it, but ignoring that side of it is doing a disservice to women, I think.
I completely agree. And I love everything you said there. So, okay, you walk through kind of pelvic floor, diastasis. Talk to me about, because obviously these things occur in pregnancy, and especially the pelvic floor can also be kind of exacerbated in childbirth. But talk to me about how the different kinds of birth that someone has might then require kind of more treatment, additional treatment, a different approach, like, for example, scar work, whether it's from a natural birth or a C-section.
For sure, yeah. So I think often there's a huge separation between people saying, if you've had a cesarean, recovery will look like this, rehab will look like this. It's slower or quicker or X, Y, and Z. And if you have a vaginal birth or an instrumental birth, that it will be completely different and it will look like this. And in practice, it's quite surprising that it doesn't really work like that, in that actually, from an abdominal perspective, from a pelvic floor perspective, most women who have any form of birth will have some problems in some places and other problems that they're not bothered by. Yeah. So we have to sort of acknowledge the differences. For example, that irrelevant of your birth, your diastasis will be the same, because it's to do with your abdominal wall and how it has responded to carrying a baby. From a pelvic floor perspective, a lot of the challenges come through pregnancy, the weight of the baby and all the hormonal changes that happen during pregnancy. So that is a big part of a consideration, and cesareans aren't protective of pelvic floor dysfunction. But if you haven't pushed a baby out through the vagina, there won't be any trauma to the perineum. So things like a labial graze, tears, episiotomy, etc. So we do have to acknowledge that there is differences in the physiology. And there's obviously a big difference in terms of scars. So one of the things I will always assess is if somebody has had a scar or has a scar, where is it? What does it look like? Is it bothering them? How do they feel about it? So the reason why a scar is so important post-cesarean is because you've gone through 8 layers of tissue. So actually, it's a huge abdominal surgery and definitely not something to be discussed as something that's an easy way out.
Yeah.
The scar is also, it can become quite tight. And because of the abdominal wall coming back together, often postnatally, people can't see their scar. So there's a higher risk of things like infection, pain, not being able to monitor your scar as easily as if, for example, you had a scar on your knee or on your leg. So keeping a really close eye on it is very important. We also know that the abdominal wall relates very closely to the abdominal muscles, but also the pelvic floor. And if we want that whole core canister to be moving well and being able to manage pressure well, then that scar needs to be mobile too. So very important that it's pain-free, that it's mobile, and that also that people don't have any large emotional responses with their scar. Often when I touch people's abdominal wounds or abdominal scars, they might feel quite tearful. They might have experiences or flashbacks from their birth. And that's actually quite surprisingly common. And so enabling people to feel confident to touch their scar and not be scared for things to touch it, their clothes or their child or etc. is really important. And then when it comes to perineal scars, very, very important that we get them moving really well because they go through the pelvic floor muscles. So if there is a tight scar or a dysfunctional scar or a painful scar, that's going to impact the pelvic floor muscles' ability to move well, to be able to contract well, but can also contribute to things like pain during sex or pain during exercise or even pain during sitting. And that can be even more true for women who've had more significant perineal trauma, whether that's multiple tears, a longer episiotomy, or a 3rd or 4th degree tear where the tear is extended into the back passage muscles. And so making sure that that scar is moving really, really well is really important. The other thing that is sort of equally as important for cesarean or vaginal birth is your biomechanics. So generally, how are you actually moving? I think there's so much focus on pelvic floor, diastasis, scars, and that is, really important. I've just spent loads of time talking about it. But there's so many postural changes during pregnancy. The way that we exercise has likely changed during pregnancy. The way that we've moved, the load that we now need to carry. So the fact that we're probably now doing a lot more forward bending to pick up the baby, pick up the car seat, get the baby out of the pram. All of these things mean that our sort of strength, any tightness in our muscles, the way that we move has changed. And if that sort of whole body change is not supporting you in the way that you need it to in new mum life, then actually we need to make sure that that's working really well too. And that is the case for all mothers, irrelevant of the type of birth you've had.
Yeah, I love that. And I do that with clients too who've just had a baby. I make sure that there are certain specific pull and push movements in their training plan, which are going to really aid them just having their day-to-day life with their child. So I really like that you touched on that. A lot of women are fearful of the C-section pouch or find that they develop one. Can you talk about how and why that develops and whether or not it is possible to get rid of it, basically?
Very much so. So the pouch comes because the scar is very, very low. So it's in your bikini line for most women, unless there's been an emergency or unless they had to get the baby out very quickly, or unless you have sort of a different anatomy that meant they couldn't have that low bikini line scar. It's really low, which is a good thing because it means that you can't see it if you're in a bikini or when you're wearing underwear. So most people prefer that. But because it's very low, it means that the pouch often sits where some women carry more fat. The thing about that is that because the scar can become quite tight and it can have adhesions where the skin and the different layers of tissue have become a bit stuck together, if there's one area that is more tight and then the skin and the fat cells and all the other tissues that sit above that scar are less tight, it's going to give the appearance of a pouch or a shelf. Now, If someone has got a very tight scar, it makes sense that the pouch is going to be there. And if you have a more mobile scar that is not as tight or as stuck between those layers, it means there's going to be more movement and there's not going to be this pouch there. So there's definitely a lot you can do for it. So the first thing is making sure that you let the scar heal as well as possible. So that means in those early days, we want to minimize infection, because the more infection that you have, or the longer that first healing stage takes, the longer it's going to take for those adhesions to form, and the harder it is to get rid of it afterwards. So keeping it clean and dry, following any advice about what to do with your dressings, but also having a low threshold. If you think your scar doesn't quite look right, take a picture of it, send it to your midwifery team and say, I'm not sure about this. If you're no longer under midwifery care, go to your GP, get someone to have a look, especially because it's very hard to see yourself. So allowing the scar to heal very well early on is very important. The other thing is doing sensory work for a cesarean scar. So when I say that, lots of people are not quite sure what I mean. We talk a lot about massage, which I'll talk about in a minute, but sensory work is slightly different. So without touching the actual scar whilst it's healing, but touching above the scar and below the scar, you can start doing from about 2 weeks. But we're making sure that you've got really clean hands and that everything's clean and that you don't touch the scar. Just doing light strokes, light touches, gentle circles, to make sure that all of those nerves around the area don't become very, very sensitive and protective of the area. The reason why that's so important is because in order to make sure that we don't have adhesions and the scar moves really well and feels really comfortable, we need to start doing massage from 6 weeks. And if you have been terrified to touch the scar at all since birth until 6 weeks, when you first start to come and touch it, it's going to feel quite sensitive. It might have this larger emotional response. It might be quite painful, and that's going to limit how confident we feel. So doing that light touch from really early is important. And then from 6 weeks, you can start doing a massage over the scar if everything has healed well. So when I say 6 weeks, that's not necessarily 6 weeks from birth if you've had a very complicated scar journey. It's 6 weeks from when your scar sort of healed enough that is going to start that remodeling phase. And at that point, we can just start doing some gentle circles over the scar, some zigzag movements over the scar, using a really good oil, something that feels comfortable and that doesn't irritate your skin. And what this is doing is it's starting to desensitize the scar itself during that remodeling phase. And then from about 12 weeks, we can start to do a lot deeper massage, which might feel slightly more uncomfortable. I remember when we first did it with your scar, you were quite surprised.
I was really shocked at like how much of my abdominal wall reacted to a very specific part of my kind of internal scar that you were touching. It was very strange, quite enlightening actually, how you say like, no, the pelvic floor, the abdominal wall, like it's all connected, and you really feel it when you do scar massage.
The interesting thing about scar massage is that it should never be painful. We don't want to teach the scar that touch hurts. We want to just make sure that we're doing enough massage, that we're getting the scar moving and lifting. And you should be able to pick up the scar from below and above the scar and lift it away from your skin. And if you've got a pouch that's quite deep, you're not even going to be able to grab either side. So making sure that you can really pick up the scar, you can start to lift it, you feel comfortable touching it. All of these things is really important for minimizing a pouch. The other thing that's very important is silicone. So you can buy silicone patches. There's some which are very expensive, but absolutely fantastic. So the best one is Scarban, but it's about 75 quid for 6 weeks worth. So it's not available for everybody. You can also buy silicone strips on Amazon.
That's what I did.
Obviously, make sure they're medical grade. And they're only like 12 quid and they last you 8 weeks. And the discrepancy in benefit to price is, I would argue, negligible.
Yeah.
So, and what you do is you have to wait until it says about 6 weeks. Some consultants privately will let you use it earlier, but blanket rule is from 6 weeks. You put it on, you build up how long you wear it for, and that helps to keep the scar hydrated so that it can heal without those adhesions. There's quite a lot of research that using a silicone cream is not as effective as using that silicone plaster. So making sure you're using a plaster, and you can use that for as long as you want to. So most people need to use it for about 3 months, but if you're still not happy with the aesthetic of the scar, then you can think about actually allowing it to use it for a lot longer if it's going to give you the outcome that you want. Very good for making the scar be flatter, paler, less bothersome. And also it gets you used to touching the scar. So that's really useful. The one key thing about silicone plasters is they're reusable.
Yeah.
Quite a lot of women have come back in and said, Jo, this is so expensive. I can't afford to be doing this.
You leave it on.
And I said, well,
yeah.
You leave it on and then you take it off, you wash it and you stick it back on its plaster and use it again the next day.
Yeah.
So key point to remember. But I think, the other thing that's very important for scars is actually moving. So doing the appropriate abdominal rehab so that the muscles are strong and the scar is moving with the abdominal muscles is key.
We talked about your assessment, your initial assessment, the pelvic floor. We talked about diastasis. We've talked about scar work. So let's now move into actually rehabbing postnatally. What are some of the things that you like your postnatal clients to start with? And kind of what are some of the things that you prescribe to them?
A really, really important consideration with postnatal recovery is that it's all about intention, not intensity. So everybody has different goals, and it's really important that we know where we're working towards. And I love getting women back to really challenging things, lifting heavy, running marathons, doing sort of, bike races, triathlons, the works. But actually, the timeline for that will look different for everybody. And making sure that you really know what you're doing, why you're doing it, and you feel empowered to do it is so, so important. I know when you first came to see me at the beginning, you were like, when can I do all the fun stuff? And I was saying, we can do fun stuff for sure.
Yeah.
But we can do fun stuff when we've got the basics absolutely nailed. You don't even have to think about it. And that is true for everybody. There's a few other considerations as well when we talk about exercise that we need to really think about, because exercise is only effective when you can recover from it. So if you're not in a place where you can recover from the exercise, all you're going to do is affect your hormonal health, and you're going to affect your, your relationship with your body and your relationship with exercise. So we need to think about sleep. Obviously, new mum, like little baby, the likelihood of getting really good sleep is very low. But if somebody's had really, really, really poor sleep and then is trying to get up earlier to try and exercise, where is the benefit going to lie?
Yeah.
So it's all about balancing that. The other thing is nutrition. So especially if you're breastfeeding, making sure that you've got enough protein, making sure that your diet is rich enough in the nutrients that you need to recover. If you are breastfeeding, thinking about how can we maintain a good milk supply, also making sure that we're considering sort of breast health, a supportive sports bra, all these sorts of things. Making sure that hormonally we know where we're at. So have cycles returned? Have they not returned? Thinking about things like, have we got enough estrogen to maintain bone density? All of these sorts of things, and especially in women who are very low weight or very, very lean, even postnatally. And also mental health. So exercise is fantastic for mental health, but we also have to make sure that people are not driving themselves into the ground for an aesthetic goal early postnatal when mental health is really, really a priority. But with all that said, so at the beginning, from sort of about 2 weeks, we can start to do some really, really basic breath work, core work, integrating that pelvic floor muscle with the abdominal wall. Everybody says you have to wait till 6 weeks, but that's quite sort of old school. I think we need to think about exercise as a continuum rather than you can't do any exercise and then suddenly you can exercise.
Yes.
Because it's kind of not like that.
No, it's so ridiculous. It's so ridiculous that if it comes to we all understand if you were to have torn cruciate ligament surgery, it wouldn't be like, okay, 12 weeks, now you're free to go. Everybody understands that there would be a really graded return.
Of course.
But when it comes to postnatally, it's like, 6 week check, tick, bye. It's like, no.
Tick. Yeah. Well, the amount of women who come to me and say, I've seen my GP and she said I can run now. Yeah. I'm like, oh, okay. Does she look at your calf strength or your glute strength, or does she check your pelvic floor or your diastasis, or ask if you ever ran before? So I think it's important to think of it as this continuum. And that's why, as long as everything's going okay, sort of some basic movements, some breath work, coordinating the pelvic floor, coordinating the abdominal wall, very basic Pilates type exercise, like a single leg raise, like a bridge. There's no reason why we can't start doing those things from about 2 weeks. If you're getting in and out of bed, there's no reason why you can't start to activate your abdominal muscles. Yeah. The other thing to mention is that you can start pelvic floor muscle training, so exercises for the pelvic floor, from very, very early postnatal, and it's actually really good for recovery. So as soon as you have been for your first proper wee that has been signed off by your midwife as a big enough wee, they're not worried about your bladder function, whether that's after a catheter or just after birth, that means that you can start doing your pelvic floor exercises. And you just start with very, very gentle squeeze and full relax from the back passage as if you're holding in wind, to the front as if you're holding in a wee, and then relaxing all the way back down. And we're not aiming for 10-second holds or anything like that. We're just starting to re-coordinate the body, trying to refine the pelvic floor. It will help to bring blood to the scar so that it can heal. It will help reduce any swelling. And most women find that immediately post-birth, they can't really feel their pelvic floor muscles at all because so much has gone on there. And that's nothing to worry about. But starting to reintegrate that from early can be really useful. And then for about 2 weeks, we can integrate that pelvic floor, abdominal wall, low-level sorts of exercises, getting used to the idea of moving again. At this point, it's going to be predominantly sort of lying down, side lying, on all fours, so that you can really focus on that intention rather than having to stabilize your body at the same time. From around 6 weeks, and again, 6 weeks with a pinch of salt, it will be different for everybody. That's when we can start to think about more functional exercise. Let's think about getting more upright. Let's get a little bit more stronger. Let's push a little bit harder. Let's work into exercises that are going to improve our global strength. So things like squats, lunges, starting to work the upper body, trying to get a little bit stronger from that perspective. We're working on global strength. And then from around 12 weeks, that's when we're going to start to think about the real goal that you've got and how we're going to get you there. So we're going to start adding in things like impact. We're going to add in things like resistance. We're going to try and start working on a specific thing that you need to get to your goal. So if that's running, we're going to start adding in things like hopping, forward bounds, hopping backwards, jumping off boxes. If it's something like weightlifting, that's when we're going to start thinking about, okay, we've got you strong, but now we need to really focus on what is your technique if I even just put a broom handle in your hand? What happens? What happens to your pelvic floor? And working on that, and then you can build up your resistance, build up your weight, which is exactly what we did with yourself.
Yeah, no, I loved it. I mean, I will say a couple things just if anybody's in a funny headspace with it, which I was okay most of the time, but I definitely had moments where I was really upset or embarrassed that Jo would be like trying to get me to engage my transverse abdominis, which for anyone listening now, if you just think I'm about to be kind of punched in the stomach, it's quite an easy cue. You kind of feel that kind of in a corset tighten. I couldn't do it. Like I could not do it. And I was trying so hard. And Jo, obviously, this is her job. She's seen it all before. She's so patient. She's like, okay, why don't we try this? And I was so upset and like embarrassed. I think I cried the whole way home. And I was like, what's happened to my body? Like, am I ever going to get it back? And I just want to say to anyone listening who's like in that really horrible phase of like, I don't like internally recognize my body, like put aesthetic to one side, but like, I don't feel like this is my body. You will get it back and it will get better. And it is just a very frustrating time that requires a lot of patience. It's nothing more than that. So don't let it scare you. But yeah, it was really, really hard. I feel like my pelvic floor has always been, I don't know. I never really struggled with that side of things other than to relax it. But my core muscles were shot after pregnancy.
I think as well, for people who have never really done any exercise, but suddenly panic postnatal, the feeling of not really knowing what you're doing, feeling a bit overwhelmed, is quite familiar. Yeah. But for people who are high-level athletes, whatever that's come from, to suddenly have a body that doesn't feel familiar and having to use different cues, think about this. I mean, when we were trying to get your core firing up, we were thinking about all different ways of getting it moving. Yeah. And I think sometimes having to take a step back and then reapproach it differently can be really intimidating. If your body has relied on certain cues, certain feelings, thinking about things in a certain way, standing in a certain way, and it just happens. But then actually postnatally, it might not just happen anymore. Yeah. And actually, it only took you a couple of weeks and you came back and you were like, I was in the gym and I was not going to leave until I'd done it. And now I could do it. And I was like, well, there we go.
Yeah. No, it's so true. Yeah, you're right. I think for some people, maybe who don't have that knowledge of their body, it would be very overwhelming to now in a postnatal body, which is just kind of all messed up. It would be very overwhelming to now try and figure out how to engage certain muscles and feel it. But yeah, when all of a sudden you can't do it anymore, it's quite scary. This episode of the podcast is sponsored by Simprove, a science-backed water-based supplement containing billions of live and active bacteria that support the gut. The podcast loves to discuss all things gut health, and Simprove are here to support these conversations. I've actually been taking Simprove for years now. It's a staple of my morning routine, helping support my overall gut health and function. It's such an important part of my routine. I even take it on holiday with me to ensure that I'm supporting my gut health, which we all know can do strange things when traveling and eating different foods. Simprove is a non-dairy food supplement proven to deliver live and active bacteria straight to the gut, so it can truly have an impact. 9 out of 10 customers report feeling a beneficial difference after taking Simprove and continue to take it daily. Simprove are offering a 50% discount on your first 3-month subscription. Use code BODCAST50, that's BODCAST50, to order yours today. Visit simprove.com and use code BODCAST50 for 50% off your first 3-month subscription. Okay, so we talked about kind of the physio rehab journey. How do you determine, okay, this client is ready to go back to training, whether it's running, weightlifting, or any kind of performance goal? Because as you said, everyone's different. For me, I was like 16 weeks postnatal till Jo was like, okay, you can lift heavy now. And even then there was an assessment and there was a limit. So how do you do this from client to client? What are the signs that you look for that this person is ready to get back to full throttle training?
A really key point that you've just highlighted really nicely is that it's not a time. So people often say to me, how long is it until you can run postnatally? And yes, the return to running guidelines say not before 3 months, but it also might not be before 2 years if you're not strong enough, if you haven't done the pre-work. So making sure that it's not a time, but also it's also not just a tick off. Exactly as you said, at 16 weeks, I was like, right, now we've done all of this work, we've checked everything, it's looking good. I'm really happy for you to go and lift X weight. Go do it, get strong, enjoy it, and then come back, and then we'll reassess, check everything's okay, and then we'll push the weight harder, and then we'll push the weight harder, and it's a process rather than a tick. And so if you ever are getting a check from a GP or from anybody that you're working with who says, oh yeah, you're good now, you can go and do whatever you want, I would be slightly skeptical because we want to make sure that, especially if you've got big goals, if you want to be running far or really fast or lifting really heavy, or you want to be spending a prolonged amount of time in a saddle, you really want to make sure that someone is regularly checking in, because you don't know in terms of, if you just get left to it, you might be doing it perfectly in the clinic room when somebody was watching you. And then when you're by yourself and you've got your headphones on and you're jamming along to your favorite song, is it still as good? Potentially not. So keeping an eye on that. The main things are making sure the pelvic floor is strong enough, it is mobile enough, it is coordinated, and it's got the endurance. So, for example, there's a fantastic return to running guidelines written by 3 brilliant physios. And if you Google return to running guidelines, it's the first thing that comes up. And that outlines lots of things that you need to be able to do. So it says that you should be able to, in standing, do 10 full range sort of fast contractions of the pelvic floor, 8 to 12 reps of a 6 to 8 second maximal pelvic floor contraction in standing. And you should be able to hold a submaximal pelvic floor squeeze for 60 seconds in standing and be able to fully relax afterwards before you consider a return to running program. That's not running, that's like couch to 5K. So I think when we think about it like that, everyone suddenly thinks, oh, actually, that's quite challenging. So the pelvic floor needs to be able to do all of those things, but it also has to be able to relax fully afterwards so that we're not ramping up tension, which could contribute to things like pain. It could contribute to things like pelvic floor tightness, which might cause bladder or bowel issues or pain with intercourse. So really important that we're considering that. We want to make sure that the abdominal wall is working really well. A little bit of that soft doning between the abdominal wall muscles as you're doing your rehab, we're not necessarily hugely worried about. But if you start to get a really pointy tummy or a big dome in the middle that's quite firm, that's a sign that we're not ready for the exercise that we're doing. And then exactly as you mentioned in terms of something like ACL rehab, you need to be able to have the strength to do the thing that you want to be able to do, whatever that is. So you need to make sure that your whatever other muscles are strong enough are working well to make sure that that goal is achievable. So making sure that we're checking all of those things, and then that someone is actually mentally ready to do that activity. If somebody has a history of disordered eating, disordered relationships with exercise, and they're desperate to run because actually they're really struggling with baby blues, then is it a really good idea to start running excessively? Or do we need to address any of those concerns alongside a really graded return to the exercise that they want to do?
Yeah, I absolutely love all that. What are some kind of warning signs that you will hear from clients that make you think actually you're still not ready and we've still got some more work to do here?
So I think the one that everybody thinks about is the bladder. So if you're having any leaking at all, this whole concept that we can laugh about it, I think we need to get rid of.
Yeah.
It's a sign that things aren't working well.
Yeah.
It's not funny. We need to respect our pelvic health. And, if something like that's holding you back, then I think we need to get on top of it.
Yeah.
So any leaks, but also things like if you can't fully empty your bladder, or you're having any pain with bladder filling or emptying, or if you're having any of those overactive bladder symptoms. So things like going too often, having urgency, especially when you put the key in the door, all those things are a sign that something's not working well. Similarly with the bowel, if you're having any accidents, even if it's that you can't control wind when you stand up from the sofa, that's a sign that coordination's not there. But things like constipation or straining or urgency with the bowel, all of those are again a sign that things aren't working as well as they could be. A prolapse is when one of the organs of the pelvis, so it could be the bladder, the bowel, the uterus, or it could even be the small bowel, starts to descend and lean on the vaginal walls. And that can cause symptoms of heaviness or feeling like there's a tampon in when there isn't, or a dragging feeling, or you might see a bit of a bulge at the vaginal opening. Now that, people then Google prolapse and think they can never, ever do any exercise and it's the end of the world. And that is completely not true.
You said it's actually really, really common and that a lot of women...
It's really common.
So this is the thing. I just want to touch on this and then I'm going to throw it back to Jo because I think this is really important. A lot of women, myself included, before I started seeing Jo, see this prolapse as this big kind of demonstrative occurrence, this thing that happens, and it's horrifying and it's terrifying. And like you say, a lot of women think that they, can never lift heavy again, never do a heavy deadlift or a heavy squat or whatever. And then I started seeing Jo and I started asking her about prolapse. She was like, it's really common. Loads of women don't even know that they've got a really small prolapse. And I was like, oh, there are varying degrees. And she was like, yeah, and it's really common and it's nothing to be scared of. So Jo, pick that up because I think this is really important.
Prolapses can be, so as I mentioned, the front wall of the vagina with the bladder, the back wall of the vagina with the bowel, or the top of the vagina with the uterus and the cervix. And with all of those things, there can be a little bit of movement or there can be a lot of movement to the extent that that organ actually sits just outside of the vagina through the vaginal wall. And I think the number one rule of prolapse is don't Google prolapse because you just find all of these awful pictures and lots of women who are really struggling on Facebook groups telling everybody else that they shouldn't be doing anything. And it's just not as simple as that. We used to have a grading system that graded it from 1 to 4. And then they did quite a lot of research and found that actually to have a grade 1 prolapse, i.e. when there's a little bit of movement of one of the organs, like over 50% of women who are in their 20s and 30s who haven't had a baby have it.
Yeah.
So actually it's just a vagina. Yeah. It's nothing special. It's just normal.
Yeah.
And so the other thing is that the degree of prolapse, i.e. how big it is, does not relate to how symptomatic you are. So some people might have a very, very small prolapse and have loads of symptoms. And some people might have a very large prolapse and not even know about it. So I had one woman who came in to see me and she just came to see me because she's having a bit of leaking and she wasn't hugely bothered about it. She just wanted to get checked. And then I had a look and I said, well, yeah, it's because the majority of your bladder is sitting outside of the vagina. And so we need to go and see a surgeon about it. And she wasn't even that fussed. So I think, it's important to remember that prolapse is a scale. And actually, when you have a prolapse, you definitely can still do all the things that you want to do. You can get back to running. You can get back to lifting weights. It might just take a little while to learn how to manage pressure within your body so that when you're doing things, you're not putting more pressure above your organs than you can support from underneath. Yeah. And if you don't have that support underneath from the pelvic floor, from the connective tissue, we just have to learn how to do things slightly differently. And I think the sort of language and the way that people are talking about prolapse is really changing because actually, like you say, it's so common. 50% of women over 50 have a prolapse. And lots of women might have developed their prolapse after their baby, but don't have any symptoms till around the perimenopause and the vaginal canal becomes drier and they become more sensitive. Yeah. So I think if you are worried that you have a prolapse or think that you have prolapse symptoms, the best thing to do is actually go and see somebody, get it checked, don't Google it, find out what is your anatomy and what does that mean to you. Yeah. And then they can assess you. They can assess you in lying, they can assess you in standing, they can assess you in squatting. They can have a really good look and say, okay, well, I've had a look in all of these positions and actually this is going to be fine.
Yeah.
Or they might say, we need to consider something like a pessary, which is a small silicone device that sits within the vagina to sort of support it, kind of like a sports bra for your uterus. And it holds everything up and in place. And that can be a really good way. Some people use that just during exercise or just during early postnatal recovery. Some people use it all the time. But I think the biggest thing is to take the fear out of prolapse because there are so many women who say, well, now I can just never do X, Y, or Z. And that is so limiting and can really affect your quality of life. Whereas actually, it's quite likely you can do those things. It just might take you a bit longer than someone else who doesn't have that same organ descent.
I loved all of that. And I also just find it really fascinating. And I just think it's a really important conversation to have. Okay, let me ask you this. Is it ever too late for a woman to come and see you postnatally? So let's say that she had a baby 5 years ago or 10 years ago, and may or may not be experiencing some kind of symptoms. Does the length of time between childbirth and coming to see you affect the success of her treatment?
So it's a really interesting question. It's never too late. We've got research that pelvic floor muscle training is effective at all stages of life. Physiologically, it makes sense that earlier postnatal means that you'll have had less time to develop dysfunction, i.e. less time to be straining with the bowel, less time to be pushing to pee, less time to be not strong enough externally. So it means that we're in a better time to sort of theoretically get the muscles working better. Yeah. And that is completely true. If you are sleeping at night, you've got enough money to afford a PT or to come and see me or to do the things that you feel, a gym membership, which you might not be able to. It might be that actually you don't have enough mental headspace to be doing those things. So early postnatal from a tissue perspective is theoretically better. But sometimes coming 5 years later, when actually maybe your child's now at school, maybe you've got a bit more time, maybe you're a bit more financially stable, maybe you've got a bit more energy to put into it. Sometimes that's a much better time. So actually there's no time that's too late. And the really good thing about coming to see a physio is they do a really, really full assessment. So I'll always ask you all about bladder, bowel, sex, any gynae history, what's going on with your cycle. And then you assess everything. You assess how do you move? How does your pelvic floor work? What's going on with your abdominal muscles? And then you can just start where you're at and build from there. So instead of thinking about it as postnatal is the year after having a baby, postnatal is exactly what it says on the tin. It's after you've had your baby, i.e. forever.
I love that. It's such a good point. And I've had clients say to me like, oh, I got the all clear to start exercising again 6 weeks or 12 weeks after I had my baby, and I've been back in the gym for 6 months now, and like I've missed the boat. And I'm like, you haven't missed the boat. It's never too late. Go get yourself checked out. And like better now than in a year when you might have a prolapse, it's always an option. It's always on the table.
I was just also going to mention, we were talking about warning signs, and I think something that's really important to talk about during today's podcast is about returning to sex after having a baby.
Go on.
So although it's not related to exercise, I think it's something that lots of women are really scared to talk about. They're scared to talk about it, don't know what's normal, don't know what should happen, don't know if it's just normal for things to feel different now. And actually, it's a really big sign of how the pelvic floor is working. So finding out what's going on in your intimate life can tell us a lot about what we can and can't do during exercise. So lots of women find that after having a baby, they might actually have quite a tight pelvic floor, especially if they had a tricky birth, or there's a lot going on, or they've got a history of lots of exercise, and lots of reasons why you might have a tighter pelvic floor. You might also have a scar, which is very sensitive in the perineum, or it might be that actually your relationship has changed a lot in terms of the roles that you have with your partner, or the type of sort of the way that you communicate with each other, the time that you spend together. So there's loads of reasons why things might change. So we might find that the muscles are a bit tight, and that can cause some pain. Yeah. Equally, if you're breastfeeding, the levels of estrogen are still very, very low, which means that you can suffer with vaginal dryness, not dissimilar to during the perimenopause. And so using something like a vaginal moisturizer, using lubricant during sex is really important. On the other side, though, some people find that because of a bit of weakness in the pelvic floor muscles, they might find that actually it's really difficult to orgasm, or if they do orgasm, it doesn't feel as good as it used to. And I think paying attention to all of those things is really important, because if it's not working for you in the way that you want it to, seeing someone like a physio can be really, really helpful to make sure that A, you get back to the kind of sex that you enjoy, and that you can build that intimacy either with yourself or the partner. But also it can tell us loads about what's going on from a mechanical perspective, and what do we need to do to get you feeling confident in your body again? What do we need to do to get you feeling a bit more yourself, as sort of not just as a mum, but also as yourself within that part of your life? And then also, what does that mean for all the other stuff that you're doing? How you're lifting the baby, how you're exercising, how you're running, all of these things. So I think it's really important that for women to know that it's quite common for things to feel different or not quite be going to plan. And also there's research that it's on average, it takes 6 to 9 months to get back to having sex after having a baby. So this whole concept that your GP signs you off for 6 weeks to go running, having all the sex you want, everything's just going to be fine, is quite outdated. And that if things aren't going to plan from that side of stuff, it is a warning sign that maybe the pelvic floor needs a bit of a look at.
Yeah, I love that. It's really interesting. I remember you gave me that amazing water-based lubricant, which was great. And I was an idiot at first. I didn't use it. I was like, well, it'll be fine. And I was breastfeeding. And it was like, and I have an overactive pelvic floor, and it was so uncomfortable. And then I just ended up, I think for like maybe, let me think, 9 months, I just ended up keeping cystitis sachets in my bag at all times because I just never knew when it was going to hit. And then when I stopped breastfeeding, everything went back to normal. But yeah, it is a really, and also, yeah, it does change. Like your whole relationships change. So your sex life obviously is kind of going to be a ripple effect of that. And it takes time. Like it took a really long time for James and I to just figure out how we were going to be together. Now we had a baby. It's just, yeah, you're completely right. It's really short-sighted to be like, okay, you're done, you're ready, time to go have sex now.
Especially if your partner's driving you up the wall because you've been awake all night breastfeeding, they've just been snoring, she couldn't get back to sleep, or you're annoyed that they didn't do X, Y, and Z in the house, or they're back to work and you're kind of jealous. There's a million things that could be going on.
Yeah.
But I think, it's just important to know that painful sex or really, really unsatisfying sex is not just part of having a baby.
No.
And all of those things can be improved and you can get back to having a really good sex life after baby. It's just making sure that you're seeing the right people and doing the right things.
Yeah, yeah. And patience, if you need it, is fine. Like, no pressure at all. Okay, we're going to wrap up in a minute. But just before we do, let's just talk about long-term pelvic health. What can and should women be doing in terms of their kind of, 10,000 foot approach lifestyle and life to ensure great pelvic health until they are in their old age?
Pelvic floor exercises are really important. And when I say that, I don't just mean loads and loads of squeezes, but making sure that you start doing your pelvic floor rehabilitation, including working on the strength, but also the endurance, working on making sure that you've got full range so you can fully relax your pelvic floor is really important in the early days. But getting back to more challenging exercise will also be working the pelvic floor so that hopefully longer term, we don't need to be constantly doing lots and lots of Kegels, which can make things, more complicated. Yeah. So that's really important. And getting that checked by a pelvic floor physio will always be worthwhile because if they've checked it and everything's great, lovely, you can crack on. And if they check it and things aren't quite as good, you're not wasting all your time trying to do something which isn't going to have the best outcome. Making sure that you're exercising regularly and staying a healthy weight will mean that there's less pressure on the pelvic floor. So we know that 70% of our body weight sits above the pelvic floor. So if we are carrying more weight, it's going to put more pressure on our organs. It's going to put more pressure on the pelvic floor muscles so that it will have to work a lot harder. A really important one is avoiding constipation, because if we're pushing to empty the bowels, that's going to put loads of pressure on the pelvic floor every single day. And so making sure that we're drinking enough fluids, eating enough fiber, so at least 30 grams every day, and putting your feet up on a footstool can make a huge difference when you're emptying your bowels for people who are struggling with constipation. Making sure that you're looking after your bladder, so drinking enough, making sure that you're not going all the time just in case, and making sure that you're trying to fully empty your bladder when you go and not push peeing. So make sure you're not straining to empty the bladder. I think the biggest one is if your pelvic floor is not working or your pelvic health isn't where you want it to be, not avoiding things.
Yeah.
If there's something you want to do and you can't do it because you're worried about leaking or pain or, go and see someone, get it sorted, because we've got loads of research that physio works really well for these things. And it often doesn't take that long. So depending on the problem, it might be it only takes 6, 12, 18 weeks to make a huge difference. And then you can go trampolining till your heart's content or run a marathon or do the things you want to do. So don't wait till you're a lot older if actually we know that there's lots you can do for it.
It's so important for your own, I think, mental health as well, especially, I don't know if you're menopausal or you are postnatal, just to feel like you're getting some control over your body, especially internally when it's not about aesthetics, it's about your kind of internal relationship with yourself. And I just think it's such an important thing to do for physicality, but as well as mental health. I really appreciate you coming back today, Jo. Can you, just like last time, just tell everybody where they can find you and how to get in touch with you?
So I'm on Instagram as Jo Gipson Physio, or I've got a website, jogipsonphysiotherapy.com. And also I offer complimentary calls. So if you're kind of thinking you've listened and you're not really sure, is this for you? Is this not for you? Are your symptoms normal? Is it common? Just book in. Let's have a call. Let's have a chat about it and find out what's going on and find out how we can get you feeling a lot more confident.
And I cannot recommend Jo enough. Like, also just from like a, I don't know, conversational, calming perspective, when I was having some very hard days postnatally, seeing Jo always calm me down. I was very, very grateful to you forever. So thank you.
It's very kind of you.
It's true. There's always such an emphasis on you always approached everything with such an emphasis on how I was feeling like in my head. And it was just, it makes all the difference in the world, especially when you're talking about an area as kind of sensitive as this. So yes, I obviously cannot recommend her enough. Thank you guys so much for listening to this episode of the Bodcast. We will be back with another fantastic guest. If you like the show or any episode of it, please do like, subscribe, leave a review, put it on social media, tag me. It all makes a huge, huge difference. Thank you so much.